Hi, everybody. Welcome to week one of patient assessment, PTA 2310. Obviously, I am not thrilled with us having to do a recorded lecture for this class. In the many years that I've taught this class, never have I had to do a recorded lecture for week one. But we're going to do the best we can, and we'll make it work, just like we've made pretty much everything else work during this national pandemic. So hopefully it's coming closer and closer to an end and will stop affecting us so greatly. So this lecture is going to be covering inspection, observation, and palpation. And I'm going to go ahead and present my PowerPoint now so that you can see it. Know that I posted a PowerPoint for you, or this PowerPoint, in Module 1. So there's going to be some areas that you'll need to take some notes on, just to kind of help you follow along with my recording. So it should be posted in Module 1 for you. And then we will be covering in lab, so January 19th. I'm not sure what date you'll actually be watching this, but we'll be covering in lab some of the techniques that we talk about in this lecture, but mainly more the techniques that we talk about in the next recorded lecture for this week, which will be vital signs and how to assess those. So let me go ahead and present my screen. And I'm hopefully going to be able to do this without being interrupted. All three of my kids are still home doing online learning as well. So fingers crossed that we can get through this without too many interruptions, like my dog. All right, so hopefully you can see my screen. Okay, so as I said, this recording is going to talk about inspection, observation, and palpation. So when thinking about those three terms, I'm assuming palpation is probably familiar to you, just coming out of kinesiology. A lot of what you did in there was touching and feeling for the muscle belly and the origin and insertion of the muscle. So you had to do a lot of palpating in that class. So palpation for this class, for patient assessment, means the same thing. What are you doing as far as an assessment perspective, from a touch perspective? Inspection, when we talk about inspection, we're looking more at what you're looking at. So you can tell a lot by a patient. You can assess a lot about your patients just by looking at them, without them doing any movement, just by looking at them in a stable position. There's a lot that you can assess. And then observation, we're going to look at observation in more of a terms of watching what the patient does. So watching them move. And so that's going to be the difference between inspection and observation. Is inspection is you're looking at them at rest. Observation is you're watching them when they're in movement. So observations, inspections, obviously should begin when you first see the patient. So you should always be looking at the patient from a full perspective. That would include, what do you see from them anteriorly? What do you see from them or on them from a posterior perspective? And then as well laterally, what do you see from a side description or side view of your patients? So you can notice a lot, or you can assess a lot about your patients just by what you see. So when they're just sitting there, what are some of the things that you think you can tell about your patient just by looking at them before they even move? I'm going to give you a couple minutes to try to think about that before I give you some ideas. So some of the things that I think about, just that I can assess about my patients just by looking at them, one would be their arousal. Are they awake? Are they sleeping? If they're awake, are they awake with their eyes open? Are they awake with their eyes closed? I also can see just their mood by looking at them. I know when I walk into a patient's room, if they're up in their chair and they have a smile on their face and are happy to see that I've walked in the room, I have a pretty good indication that this is probably going to be a pretty positive treatment experience. But if I walk into a patient's room and they're either laying in bed, or the room color can also be a huge indication for me how the treatment process is going to go. If I walk into a patient's room and their lights are off, their shade is pulled, they're sleeping, or their TV's not on, and they may have a frown on their face, that I can usually tell right away that, you know what, this patient probably isn't having a very good day. There's a high likelihood I'm going to have to do some major encouraging to get them to want to participate in therapy. We can also notice our patient's strength level at times just by looking at them. So if I'm looking at a patient sitting in a wheelchair and they're leaning to one side, and I can tell, or maybe their foot is placed in an awkward position. I can tell a lot about maybe their sensation level. Can they even feel where their foot is in space? Is it just weak and that's why they can't place it in the proper place, say, for example, on the footrest? So I can look and almost have an idea, or at least begin to assess my patient's strength level, their sensation level, just by how they may be positioned in a chair. So going along with that, for example, if we get to inspection again, one of the first things that we can notice about our patients, again, inspection means looking at them, is we can check for any check for the symmetry and the alignment. And so we're looking for any asymmetry or any malalignments that we may see. So this could be, any asymmetries could be indicative of a fracture potentially, or dislocation. So if we see a bulge on a patient's arm or a leg, that can be indicating that maybe there's an underlying fracture. Any congenital variations, we can notice just by asymmetries, muscle tightness, muscle weakness, like we already talked about. Edema is a huge one that we are able to see quite clearly when we're looking at our patients. So obviously edema is a word for swelling. So we can, absolutely see that just by looking at a patient. And we can also identify muscle hypertrophy. So a muscle that is bigger in size than it should be, versus muscle atrophy, which is a muscle that is smaller in size than the contralateral side. So usually that means it's weak or paralyzed, definitely getting less use than the contralateral side. So, and it doesn't necessarily have to be paralyzed. After my husband had his knee replacement a year ago, when I look at his knee even now, or his quads even now, he's still quite atrophied on the surgery side. So sometimes it takes a long time to get that back. Sometimes patients will never get to the point where they were before surgery, unfortunately. So just as an example, if you were to walk into your patient's room and they were sitting in a chair and they were leaning to the right, what do you think could be potential reasons that your patient would be leaning to the right? So I'm going to give you a couple of minutes to think about that. All right. So if you walk into a patient's room and you see that they're leaning to the right, then what this could indicate is maybe some trunk muscle weakness. So maybe they have some trunk weakness, and so they're leaning to the right. Maybe they have tight external and internal obliques on that right side, which is causing them to shift over to the right. Maybe they have some decreased proprioception, so they don't know where, they can't feel their body in space. So for them, it might feel like they are actually sitting up straight up and down. They might not realize that they are even leaning to that side. That kind of goes along with like a lack of midline orientation, which can happen after having a stroke, especially a cerebellar stroke, which is a stroke in our valence center of the brain. And they might also have what's considered left inattention. You'll learn a little bit more about that in neurological management. I'm not sure if you talked about it in neurological foundations or not, but left inattention or left neglect is where a patient will have a visual disturbance. They actually lose the one half of their visual field, usually on the side that's affected. So if someone has had a left or right stroke or right CVA, which has affected the left side of the body, the left visual fields would be cut for them. So in reality, what happens is they almost are completely turned to the right because they have to compensate and turn to the right, or what's normal for them, I'm sorry, is for them to only see out of the right side of their visual field. So they actually have no idea that they're missing the whole left side of their environment. And so a lot of times our patients who have that will present with their posture totally turned to the right, but they have no idea that they're doing that. So again, something else that you might be able to figure out just by looking at your patient. Other things that you want to continue to look at or assess just by, again, inspecting or looking at your patient is their skin color and the nail bed color. So if you notice that a patient has more of a blue discoloration to either their skin or their nail bed, this is called cyanosis. And this can be an indication that your patient is not getting enough oxygen or they have too much carbon dioxide. So that is something that can be pretty serious. And another area that you will typically see this for our patients who are struggling with oxygenation is usually around their lips or their mouth will start turning a bluer color. Paler is more of a whitish or pale color. So if you've ever seen somebody who's about ready to pass out, you know how you'll see some people that are fine 1 minute and then all of a sudden they go completely white. The word for that is paler. And that just usually means that there's a decrease in blood flow, decreased hemoglobin, and a common reason for this can be internal bleeding or anemia. Eurythmia is localized redness. So it usually indicates an increased blood flow. Usually when we see redness, it's because there's some inflammation or an infection going on. And we tend to see this with someone who has a fever as well, especially in their face. I can always tell when one of my kids has a fever because they get those red cheeks, and sometimes it goes onto their nose and their forehead, but usually it is because usually it's in their cheeks that I can tell, uh-oh, something's not right. You must not be feeling well. And then a yellow skin tone usually is indicative of liver disease and sometimes some kidney issues as well. You may see more of a yellow tinge to your patient's face. One thing to keep in mind with the paler is one thing that I have learned throughout many, many years of patient care is that our patients aren't always the best for whatever reason. I'm not 100% sure why, but our patients aren't always the best at letting us know when they don't feel well. I don't know if sometimes they're worried or they keep thinking, well, if I just push through it, I'll be okay. But one thing that I've learned over the years is sometimes it is maybe seconds from when I notice a patient having some pallor to them passing out on me, or coming very close to passing out. So that is definitely a skin color that you don't want to ignore. If you notice that your patient has that coloring, definitely check in with them and see if they're feeling okay. And even if they say, yeah, I'm good, you may want to just have them sit down and take their blood pressure, take their heart rate, just to make sure everything is okay. Because like I said, what I have noticed is sometimes it doesn't take long at all for my patients who go from a normal coloring to paler to be completely passing out. So keep an eye on that. And then the third thing that we can definitely want to be looking at from our patient's perspective is anytime they have an incision. So when when a patient has an incision, there's four main things, actually five. There's five main things that you are going to want to pay attention to, and absolutely for sure document these in your notes. But you're going to want to note the location of the incision. You're going to want to note, are the staples and stitches intact? Okay. So is there a staple that has potentially popped out or is missing? Has part of the incision maybe come undone? So that's definitely something you're going to want to note, and then obviously direct toward the, make sure the nurse is as informed as well, or the physician. Any redness, again, could be indicative of an infection or an inflammation process going on. So we for sure want to stop any infection as soon as possible. Because, any infection that's left untreated, as you know, can quickly get worse and then ultimately potentially get into the bloodstream, which is never good because then it starts causing organ failure. So we definitely want to catch infections as soon as possible. Another thing you want to look for is drainage. So there's always a normal amount of drainage. Okay, so you don't need to freak out if you have a patient that has a dressing on and you see some drainage coming from the incision. Some drainage is actually normal, and you would want that for healing purposes. But when you start seeing an abnormal amount where your patients are actually seeping through a bandage very quickly, or if you start seeing more of a cloudy type of or like pussy type of drainage, that obviously would be abnormal. Normal drainage should be more clear. So like I said, some drainage is normal, but when you start getting an excessive amount to where they're seeping through bandages, then you definitely want to bring that to attention of the nurse. And then any foul odor. So again, going along with infection. So you will typically know that very, very quickly. It's not like you have to get very close and actually try to smell incisions. You will know for sure if an incision has a foul odor. It will be very apparent. So again, that is something you'd want to bring to the attention of the nurse or the physician. And then you're supervising PT as well. Okay. So as far as inspection, again, going back to what we just covered, we talked about the three things that we can look at to begin assessing our patient is their bone and soft tissue alignment. So checking for any asymmetries, looking at their nail color and their skin color. And then thirdly, as we just talked about, looking at their incisions. So those are the three things that are commonly assessed just by looking at our patients. Okay. Now we're going to talk, I'm sorry, we have one more thing to talk about as far as what we're looking at. We can easily see by looking at our patients their overall size. So we can easily assess our patient's height, we can assess their weight, and we can't necessarily assess their BMI specifically by just looking at them, but we can tell by their height and their weight with the relative area of their BMI, and if they have a higher BMI or a lower BMI, just by looking at them. Another thing that we can look as far as anthropometric measurements or measurements of the size and proportions of the human body would be leg length. And a typical way to measure that is the ASIS to the median malleolus. Volumetric measurements is typically used more for hands and feet. So especially when a patient has a lot of swelling in their hands and feet, this is one way that you can document maybe improvement on how treatment is affecting the swelling in the hands and the feet. So it's typically done by submerging the body part in a container of water and then looking at the level of volume of water that is displaced. And then circumferential measurements are very common and definitely something that you should be assessing with your patient anytime they have edema. So it helps to try to figure out, okay, Is this more muscle atrophy? Is it hypertrophy? Is this edema? Is there an infection process going on? And so we will actually talk about how to do that. And this is one thing that we're going to do in lab, is talk about how to do circumferential measurements, and then on body parts. And then there's a special way to do it. It's called a figure 8 pattern for the ankle and foot. So that is something that we will be discussing in lab. Okay, so that are the 4 things that you're going to be looking at to assess your patient. So now we're going to talk about observation. What can we assess about our patients by watching them move? Okay, so we're obviously going to be looking at our patient's ability to perform basic functional tasks. Okay, so we're going to be looking at how they change position, how they are transferring, how are they doing going from a seated position to standing up, how are they doing walking. All of these are going to be those functional tasks that we're going to be able to look at our patient, watch what they're doing to see maybe some symptoms, maybe some things that they have going on. And it's going to help us determine, what do I want to focus on during my treatment sessions? Obviously, you have to follow the PT's plan of care, but usually the PT's plan of care in many situations can be very broad and ambiguous. So really paying attention to how our patients move are going to give you an indication of what you want to focus on in your treatment session. So say, for example, you go into a patient's waiting room, you're an outpatient center, and your patient is waiting for therapy, and you go to get them and say, okay, Mr. Smith, it is your turn to have therapy today. There's a lot you can see just by your patient going from the waiting room to the treatment area. So I'm going to give you a couple of minutes to think about what you could potentially be looking for when your patient goes from the waiting room to back to the treatment area. All right. So just coming from functional mobility, hopefully you guys were reverted back, dug some of the cobwebs out based on what we just covered in functional mobility. So one of the things I would look at is, how did they go from sit to stand? Did they have to use their hands? Did they scoot forward first? Did they lean their body weight forward to stand up? Did they stand up pretty stably, or did they stand up and then kind of lose their balance as soon as they stood up? When they stood up, did they have to push their legs at the back of the chair to basically propel themselves forward? Or were they able to use their quads effectively to be able to go for that, from that sit to stand position? Again, did they lose their balance? Did they have to, bring their body weight forward maybe 1 or 2 or 3 times before they were actually able to stand up? Were they able to stand up without pushing off from the chair? Did they push up with both hands or just one hand? Once they stood up, did they seem to have, pretty good balance? Did they say anything about, wow, I feel dizzy, or I feel lightheaded? If they're using an assisted device, did they have it on the correct hand according to the diagnosis? Did they use their assisted device correctly? Is the assisted device at the right height? So a lot that we can look at from just watching our patients go from the waiting room to the treatment area. Are they limping? Does it look like they're in pain? How fast are they moving? Are they moving at a normal pace? Or is it taking them 5 minutes just to walk from the waiting room to the treatment area? How's their endurance? Are they short of breath? Are they able to talk to you pretty freely when they're walking into the treatment area? Or are they winded? So a lot, like I said, a lot of different assessments can be taking place before you're really even doing anything specific with your patient, just by watching them walk from the waiting room to your treatments area. So another thing that we definitely look at as part of the function is that gait analysis. Gait is a huge part of what we do as PTs and PTAs. So I know in kinesiology, you guys covered what normal gait is. Hopefully, most of you have also made it through the review assignment that I posted, or I'm sorry, that I emailed you at least a week ago now, I believe. And it basically covers it. The review, I'm sorry, is based from Cameron chapter 32. Again, talking about what is expected from normal gait. You're not going to be able to do a whole lot about recognizing abnormal gait if you don't have a good indication of what normal gait is. So the gait cycle, do you know what the subdivisions of the stance phase are? Do you know the subdivisions of the swing phase? The standard terms for gait versus ranchos los amigos. What is cadence? Why is that important? What is step length and why is that important? Single limb support, double limb support. Why are these terms important? So if you know, like I said, normal gait, then you're going to have a much better ability to recognize abnormal gait. And then you're going to have a better ability to point out or to look at, okay, what do I want to focus on in this treatment session today? One thing that I am going to do as well is last semester, I emailed you guys a video about documentation from PT Education or PTEdSolutions.com. They were offering free videos, and I just checked today, and those videos still look like they are available. And they actually have some really good gait videos as well. So I'm going to be emailing you guys another video that I want you to watch, and then just email you some questions as well to think about as you're watching those videos. It won't be worth any points or anything like that, but it's definitely areas or topics that I would want you to understand that could potentially be on a test, just because, again, you need to know what normal gait is before you're going to be able to recognize and treat abnormal gait. So I'll be emailing you those videos, that video link, as well as the questions to kind of keep in mind as you're watching the videos. I would suggest watching the videos and then looking at my questions to see if you were able to answer the questions without going back to the video. So just some Cameron, I don't know if you realized in the Cameron text that he talks about his clinical pearls. So some of the clinical pearls that he noticed or talked about with gait is double limb support time often increases in dysfunctional gait. So again, double limb support is when both legs are in contact with the ground at the same time. And then improvements in gait are indicated by normalization of gait velocity, step or stride length, increase in single stance time, or a decrease in the amount of time that both legs are in contact with the ground at the same time. All right, so those improvements in gait, what part of your note do you think the improvements in the gait would be appropriate for? Where would you be indicating the improvements that you note for gait in your note? Give me a couple of minutes to think about that. So hopefully, documentation wasn't too long ago. Hopefully you would remember that is where you would want to put that information in your assessment. So again, the biggest part of the assessment, in my book anyway, is proving our need for skilled physical therapy. The assessment is where the insurance companies are going to look to see, why are we paying for this patient to have therapy? What is the difference between them going to therapy versus just going home with a home exercise program? So that is definitely going to be where you are noting the differences. What effects are your treatment strategies having, if any, on your patient? So the more you can, what I like to call beef up your assessment portion, the better it's going to be for your documentation to prove that need for skilled physical therapy. So I'm actually going to stop at this point and stop this video, because, and I apologize if we might have quite a few videos this first week. I just don't want to do too much in one video because it makes it really difficult for you guys to download these videos. So I'm actually going to stop at this point for this video. And then in the next video, I will pick up and we'll start talking about some common gait deviations that you are going to see when a patient is impaired.